So after that very entertaining Meet the Student session, we have probably come to the most academic part of the alumni reunion, which is the CME session, but we'll try and keep it as interesting as possible. So we have an array of esteemed speakers here with us. We will start with the first speaker, who is from the batch of 1987, Dr. Suviraj John. Dr. Suviraj John is a senior consultant surgeon in Sri Gangaram Hospital, New Delhi. He is a teaching faculty and academic coordinator for the postdoctoral fellowship in minimal access surgery under the National Board of Examinations. He's actively engaged in proctoring and mentoring surgeons across India in basic and advanced laparoscopic surgery. He's co-authored a lot of books related to this field. He's also the founder of the Minimal Access Surgical Clinics, which is a professional academic resource for training and practicing minimal access surgeons. He is an active member of many national endosurgical societies and invited faculty for many academic events. Presently, he is also the member of an expert group of national guidelines on patient safety for the National Patient Safety Implementation Framework of India, which comes under the Ministry of Health and Family Welfare, Government of India. He's also an assessor of NABH and healthcare organizations. So presenting to you, ladies and gentlemen, Dr. Suviraj John.
Thank you, Dr. Susina. Thank you, college, and thank you, batch, for this very unique privilege. My unique task this evening is to, yes, give you a CME grade presentation. But primarily what I'd like to do is, over the last few decades, we've become comfortable with obesity and overweight as a species. This evening is to introduce a little discomfort with that and a sort of call to action. The new generation of medical students are going to actually encounter the main body of the tsunami, which is obesity and the metabolic syndrome that comes with it. Dr. Nihal Thomas, I think, is going to expand on that. We've begun to see the initial waves, and a lot of us have been sold this visual, There's a patient of mine, she's a film actress, producer, fashion designer, among other things. And she sent this picture, and this carries a certain message, but that's not the whole message. And I'm going to, start doing that now. So it starts pinching you when it starts to cost. One of our first patients was a member of parliament who actually ended up paying a double ticket price in the US, and that's when he decided he needed bariatric surgery for an airline ticket. And since 2013, it's officially now, according to the Americans as well as the World Health Organization, obesity is a disease. It's a sickness, and it requires to be evaluated and treated appropriately. What is troubling is the exponential rate that it's growing, and that's going to actually form almost 1/3 of the developed world's humanity. And this is a price we can't afford to pay. Now, to get a little medically and technically precise, I'm going to be dealing with the far extreme bits of obesity, which requires intervention as a salvage intervention. Essentially grade 2 and grade 3 obesity, where the body mass index is above 32.5 in the Indian setting. By definition, this is a life-altering and a life-threatening disease, both in the short and long term. Having said that, most patients have at least one comorbidity like diabetes, hypertension, obstructive sleep apnea, and about half have more than two. And this results in a significant shortened lifespan, increased visits to the emergency, hospitals, ICU admissions, lesser chance of survival through these crises. Treatment-wise, everybody tries lifestyle management, but at clinically severe obesity, which again, by definition, a BMI of 32.5 and above in India, at a 5-year treatment span, most fail. Almost 98 to 99% people fail, even with medications. Sadly, unfortunately, bariatric surgery remains the only way forward for them. And in 1991, experts got together with the available evidence in the US and actually began a consensus statement which enabled insurance to start paying for them in the US, and then it percolated through the world. What about India? Look at the graph. This just got published a few months ago from our national body, the Obesity Surgery Society of India. We do over 20,000 bariatric procedures in our country. And this is not funny. Some of the trends in the procedures, we have some newer procedures taking precedence. By and large, we have these three as the main body of operative choices. The one to the far left is sleeve gastrectomy, which occupies probably about 60% of the population. 10 to 20% would be a Roux-en-Y gastric bypass, but increasingly we have surgeons opting for one anastomosis gastric bypass for the fact that it allows a person to eat well and yet have bypass-grade weight loss. Long-term sustainability, this is for the medical students and the junior doctors. It's been seen that up to over 10 to 15 years, you still have sustainable weight loss. This is the gastric bypass group. But here's the real bonus. Up to 80 to 90% of comorbidities from diabetes, type 2 diabetes, hypertension, sleep apnea, asthma, actually resolve. I use the word resolve with a little caution because we need to see the long-term outcomes of this. At least in the first 5 years, the resolution rates are in excess of 60 to 70% for most of these comorbidities. We look at diabetes with more concern because that's prevalent and that has a big price to pay. And depending on the severity or the radicality of the operation, a simple band would cause you a resolution rates of about 60% to about 95% with a bypass, severe malabsorptive procedure. It's translated from some of the evidence we've seen from Europe, lesser mortality. Now that's what really actually changes the game. Within a year of the bariatric procedure, you actually reduce mortality from sudden unexplained death by 95%. So that's a big, big bonus. This is a snapshot you could keep in India. The body mass index points is 2.5 points less than the West. So we start considering bariatric surgery for somebody who's not lost weight by lifestyle management medications from 32.5 and upwards, especially if they have a significant comorbidity, and 37.5 and upwards without comorbidities. And this is generally the age group of 14 to 65. Counseling begins, evaluation, and then the patient, if they're willing and committed, they go ahead. Now, a different visual from the one you saw in the second slide, at the cost of what seeming self-advertisement. This is something I did many years ago, and this patient actually agreed to share her photographs. So, young lady, 22, if I'm right, 30, a body mass index near 40, diabetic, hypertensive, IgA nephropathy with nephrotic grade proteinuria. She underwent a sleeve gastrectomy because bypass carries a risk of hyperoxaluria. A few hours she was walking, discharged in 2 days. She came back in about 10 days, fully active. She took a flight back home. She came back at 3 months. She had lost 18 kilograms, had turned euglycemic. Her hypertensive medications had come down to half. Her IgA nephropathy actually disappeared. The nephrotic grade proteinuria that went away. There are other photographs she sends to us. So roughly at 6 months, she lost some more weight. We've last seen her a couple of months ago. She's put on some weight, but she's active. She's non-diabetic. To give you a little broader scope, I'm going to come down to some research results. This is the spread of patients we have at our institutes, the first 500. So most of them are they are in the morbid obese group, and we're now seeing more people coming with super obesity. It's about 50 kilogram per meter squared, and then super obesity above, super obesity above 60. In contrast to this, I'll grab your attention to one aspect. The average BMI of the diabetic when I did my post-graduation in Vellore was about 22.4 in my study. The average diabetic now comes in 40s. So this is a different creature, and Dr. Nihal Thomas, I think, is going to speak on that. At about 5 years, we see about 60 to 70% of excess weight loss with our with our sleeve patients, the sleeve group. And we see there, within the first year, better glycemic control, as seen evidenced by hemoglobin A1C levels. And we've taken another subset and checked their insulin resistance, and that steadily comes down. Now, you know that insulin resistance is a driver for metabolic syndrome. And this is actually the real attraction because it protects you against a whole lot of other morbidity. This is another set we had where we compared about 20 patients between sleeve and bypass, and we found, at least in our population, the results were comparable for standard bypass and standard sleeve. What about the 200 plus sort of kilogram or 250 plus kilogram patients? These are a unique metabolic as well as a surgical risk. We actually began to use robotic surgery because their panicles itself weighs about 100 kilograms. We have to go through about 1 feet of fat often to access their abdomens. And this tires you out, and your instruments actually have a lot of wear and tear. We found that we can complete our procedures. We've published this significant weight difference between the standard obese patient as well as the super obese. And using robotic surgery, we've killed the difference in terms of operative characteristics and outcomes. So that's the constant innovation we need to do to handle this increasing number of patients. A quick summary from India. We see for our most of the studies are sleeve patients and the gastric bypass, and now we are having one anastomosis gastric bypass patients coming in. The average weight loss at 1 year is around 55 to 75%, and most of them maintain it till 5 years. The initial resolution of diabetes is very good. We've had patients turn euglycemic the next day from taking 2 or 3 drugs, and that's because of the incretin effect. And anywhere from 75 to 100% resolution of diabetes is 1 year. They move on to about 60 to 70% at 5 years. I'll summarize my talk by reminding you, and I would say pleading with you, please look at obesity as a disease, even if it's yourself. I have a body mass index close to about 30. Dark dress can sort of camouflage it. My uric acid is going up. The diastolic is beginning to sort of waver, and my joints are beginning to complain. Do your annual health checkup. Do it quietly, privately, and see what the results are, and compare it with the last one you did. I'm not saying if you're overweight or obese, do it otherwise too, but especially if you're on the plus side, please get it done. Dr. Abraham Joseph in community medicine I really admire him because for even sometimes the most impossible situations, he'd say this is actually preventable, and he'll tell us how it was preventable. This pandemic is actually very preventable. We need to start it at the embryo level. Ensure parents are near normal body weight before they even conceive. Weight next to height is the most strongest characteristic that's inherited. We need to control the parents to help the children. And please avoid obesity and metabolic syndrome reaching an advanced stage. So once you have a patient with a body mass index about 32.5, especially with significant comorbidities, do get a bariatric consult. This offers the best salvage option for these patients. For the rest of us, every patient today, this is the American Gynecology Association, I really admire them. Their standard operating advice now is every patient, every visit, talk about their lifestyle. This is the one that's most resistant to change. Physical activity, food choices, and start a wellness program in your hospital. Many corporate hospitals have begun that. And go public with it. And please remember, obesity, and I mean clinically severe obesity, as well as even the lesser one, grade 1 obesity, is a life-altering problem and a life-threatening disease in the short and long term. You can change that. Thank you very much.
Thank you, Dr. Suviraj. That was actually a very informative lecture. We can take a couple of questions. Maybe I'll start off. When after these bariatric surgery intervention, how common do you see malnutrition in these individuals?
Thank you. Excellent question. One of the reasons we've gone, at least in our institute, to sleeve gastrectomy as the procedure of choice for most Indians is the fact that I saw in my initial bariatric cohort where I did bypass patients, almost 30 to 40% ended up with protein energy malnutrition. And the reason is because you need to evaluate them diet-wise beginning upfront. Most of our Indians, despite having non-veg, are practically vegetarians. Our protein intake is low. And once they have a bypass or a bariatric procedure, their intake goes down further, and most fail to adhere to minimum protein intake. So we've shifted down our counseling and communication to sleep first, unless they come demanding for it and they're committed and they promise to adhere to a high protein diet. So somebody with like a 2 or 3 times a non-veg a day kind of person, we have some of them, strong history of diabetes, and they want to really go for a bypass and are willing to go with its commitments. We offer sleeveless first, with the caveat that 2 to 5% will require a second procedure, which could be a bypass or a 1 anastomosis gastric bypass. So this is actually a long journey. You need to let them know this is not a, we're trying to stop selling the procedure now. You need to stop doing that. And look at this as a long-term chronic healthcare issue. That's why I think having the physicians and I think in CMC does it well with the FOCUT department. You've come together, have a weight loss clinic. I have families where we've done about 6 members or 4 members in the family having bariatric procedures. That's telling something.
Thank you. Yeah, there's one more question.
So, thank you, sir. Dr. JP would teach us about the Thrifty gene hypothesis. So you're very right. The genetics haven't changed. The environment has, and our ability to respond to that has changed. So what has happened with more energy-dense food, more of it, we don't do very well with it. We tend to put in a fixed deposit. One person in the family is a marker for the rest. And the other thing is, I think our current lifestyle is very hostile to health. Lesser sleeping hours, late hours, stress levels. Actually, we go to a 5th floor in a hospital. You can get to see widows every day, and generally they are in their 30s, because the guys who get their cardiovascular events in their 30s, those don't survive. The older guys survive. So it's changing the scene very quickly now. And I think you need to have your own statistics, your own hospital. So we look at our numbers and I know what's happening there. So once you start pooling your data coming in, don't stop depending on the Western publications, which is fine. But once you have your own data coming in, visceral obesity, central obesity is dangerous. A slim and fit guy otherwise, with a belly, don't marry him. I'm serious. I mean, you know what I mean. So that's a shortened lifespan. Central obesity is there, that's a problem, yeah. Yeah.
And a high-calorie diet.
Yeah, so self-discipline,
more than genetics.
yes, is a tough thing to learn, and so we're now having to actually motivate people and get them. Not everybody's going to succeed, but the resistance has to come in.
So I think, yeah, thank you so much, Dr. Suviraj. That was actually a very informative talk. May I call upon Dr. Susina Alexander to present the certificate. Dr. Suviraj. Thank you.
Benjamin.
So our second speaker for today is from the batch of 1992, Dr. Amita Rao. She was one of the revered seniors when I walked into women's hostel. She did her diploma and MD in ophthalmology in CMC and went on to do a PhD in clinical investigation in the Institute of Clinical and Translational Research, University of Wisconsin. Wisconsin. She's presently the research director at this research center, a core retinal imaging lab with over 70 research staff. She also has interest in developing AI algorithms for retinal research. She has received the Research in Vision and Ophthalmology Translational Award from the American Academy of Ophthalmology. She serves on a number of NIH grants supporting imaging outcomes for clinical trials and epidemiological studies. She has over 50 publications, 100 conference presentations, and is a principal investigator of over 15 grants and contracts. Ladies and gentlemen, Dr. Amita Rao.
Little note to the sound team, there will need to be sound from the laptop for this presentation. Okay, good to go, Amita.
Thank you. Thank you for that wonderful welcome and the batch for nominating me to give this talk. I think every batch gets a sacrificial person, so here I am. So I'll be talking to you about an overview of artificial intelligence algorithms in ophthalmology, and those are my affiliations, but you know, those things don't work when you come back as an alumni. So my introduction here is I am wife of Prakash Balasubramanian, who was kind of our best outgoing in our batch, so I got him. And he's staff kid, son of Bala, not OG Bala, not Neuro Bala. He's Biochem Welcome Bala's son. So that's another thing. And I have to say, I've given this talk, I keep getting called to give this AI talk quite a few times over the last 2 years, various groups, philanthropists, the Google engineers, radiologists, ophthalmologists, all over US and international presentations. And I just go and give the talk, no second thought to it. This is what I do. This is what I'm good at. But for the first time, I was actually nervous. Coming back to your home base is a different deal. So this is exciting. So here, moving on. And how do I, technical issues? Yep.
Just the arrow key down.
Yeah. Right? It's not. We need AI for this.
Yeah, shall I do it?
Maybe a mouse.
Just 1 second.
Sure. All right. There we go. We don't need AI, just a fingertip. So the goals of today's talk are to talk about the terminology and technology of AI, a little bit of diabetic retinopathy, I won't bore you with too much ophthalmology, and AI in eye care. AI is part of everybody's life. All of you use voice assistants, they're all AI enabled. You go to Netflix, it tells you, here's your recommended movies for the night. You're using Netflix's amazing AI algorithm. However, I have a very favorite definition for artificial intelligence. This is kind of, I think, sums up what AI is all about. It's the power to make the principal of the college, of CMC, sing to your tune. And watch this.
Baby shark, do-do-do-do-do, baby shark, do-do-do-do-do, baby shark, do-do-do-do-do, baby shark.
So, that is the power of AI. Thanks. Thanks to Bablu for giving permission to do this. And if you want him to say anything like, you know, a week off college, enjoy, or hostel days from now on shall be a whole week long, just let me know after the talk and I'll make it happen. So AI is any intelligence that mimics human intelligence. It's a computer programming. Machine learning is when you actually train AI in things that you know, the way you identify things. Now, deep learning is when you don't teach the AI, the computer program, what you know. It just learns on its own. And that's the amazing thing. And how does AI work? You have a model that you're developing that you want to train to identify apples from a picture. You should train it on these images that have apples. And then you test it on images and say, okay, is it working or not? So the training is on pictures that have apples, no apples. And that's called labeled data for the training. And then you test it on unlabeled data, which is just testing data. And there you show a picture, and the AI says, yep, I see apples. And then you show another picture, it says, nope, I don't see apples. And how the AI knows that that's an apple, we don't know. We don't give it any information. We don't tell it that an apple needs to be red, this shape, nothing. It just learns on its own. Training a machine to diagnose diabetic retinopathy used to be quite an ordeal. This is, for those of you who haven't seen a retina in a long time, that's a retinal picture. And it's just like how you teach medical students. You teach them about the structure of the retina, the locations of retinopathy, the lesions, all the hemorrhages, cotton wool spots, rings a bell, all those things. Artifacts of the camera, so these are dust spots, not lesions. And how do you classify severity? So you had to do all that in the past. But now with deep learning, we don't do anything. So in machine learning, we did all this training, annotating, teaching the machine everything. In deep learning, all we do is throw a picture at it and say, this has diabetic retinopathy, learn up. And because this deep learning model, which is also called CNN or convolutional neural network, does it on its own, and we don't know how it does, we call it the black box. About 5 years ago, 5 to 6 years ago, a company called Kaggle, which does some predictive modeling analytics, they do a lot of AI for various things, like you go to Spotify and say, I want Bollywood party songs, it's going to play for you. How that happens? Because of AI. So there were people who built, through this Kaggle competition, YouTube video sorting, Spotify's home value prediction, and diabetic retinopathy made it to their list. So they had a competition for that. And what they did is they put out 100 pictures and said, can anyone develop AI models that can classify diabetic retinopathy? And they had about 7,000 entries. These were people who didn't even know the spelling of diabetic retinopathy, who didn't know what it was, they didn't care. All they could do was build AI models. The fourth prize went to 16-year-olds. So that's how fluent AI is, and people can just build. You don't need to know the subject. So this caught a lot of attention. And what did we learn from the competition? That retinal images are a great area to explore these deep learning techniques. And it gave a peek into the black box and how this was happening. Soon, of course, Google, not far away, has to catch attention of all these things happening because they are the AI masters. And DeepMind and Verily, the component that does imaging research, picked up on this and said, we want to develop one too. And in a couple of years, they published Development Validation of a Deep Learning Algorithm for Detection of Diabetic Retinopathy from Retinal Fundus Photographs. A lot of the data for this was generated from India. So what did the doctors say? Well, as ophthalmologists, we were, of course, suspicious. This does only one disease, only color photos. And for those of you who are unfamiliar, ophthalmology now has an armamentarium of imaging. It's a binary output, DR detected, not detected. It's not a diverse data set, and we don't like this black box. So then, another couple of years later, another paper came, the development and validation of deep learning systems for diabetic retinopathy and related eye diseases, so everything else, and multi-ethnic populations. So what did we say? Well, this looks pretty good, challenging, interesting. Maybe it can help us get better. Maybe it could be a screening tool, but we need some sort of good validation. And within 2 years, the FDA had a submission from a company for validation of AI model for screening diabetic retinopathy. And these are used, and FDA has to say yes for their use in clinical care. So, because this is software as a device. And so that's, so 2018, the very first AI algorithm in entire medical imaging all over the body, not just ophthalmology, but anywhere in the medical systems came out from ophthalmology. And that set the stage for radiology, dermatology, pathology following that. And my part in this is that I am part of a reading center, which is, so we don't use a radiologist, right? Ophthalmologists read their own imaging. So for clinical trials and things, the reading center is where all the images are analyzed, and these are not ophthalmologists, these are people who are trained in understanding the images. And FDA considers these reads by these graders or readers as the reference standard. And so we work with these companies to bring FDA these AI algorithms to completion and into patient use. Screening requirements for diabetic retinopathy are pretty simple. You need an image, you need a diagnosis. It's very simple, and we're not complicated. Our ophthalmology things are very simple. But the process is very complex. You take an image, you check a quality, it's not good, call the patient back, somebody else has to read it. Teleophthalmology it's beautifully established, especially in India, but it's a complex process. So if you had a camera, an image, and added an AI algorithm to that, it's instantaneous, your diagnosis, and it just takes away that entire screening into minutes or seconds. And if you took this a step forward and had an iPhone take those pictures with an AI model picking up, that would completely change the scenario of health disparities, equities, you name it. You could take this anywhere, and anybody could take a picture, and you could prevent diabetic retinopathy-related blindness. And taking ahead, any eye-related blindness could be found on this. A lot of the work on these iPhone-related imaging is being done in India. I'm almost done, just a minute. Okay, so a lot of work I do is actually not in diabetic retinopathy, it's in other parts of the retinal imaging or ophthalmology, like macular degeneration and things like that. So AI can also give you insight into systemic diseases like age, gender, BMI, smoking, and by insight I mean you can look at a retinal image and tell you like what's your age, what's your gender, smoking status, your risk of Alzheimer's, dementias, including it can even predict what your HbA1c is by just looking at the retinal image. So why hasn't AI replaced the doctor yet? We talked about this training testing. This is fine, all fine. What happens when you replace like this? The AI doesn't know that apples can be green, right? Has never seen a green apple. What happens if you start throwing in other fruits? It just crashes. It just doesn't know anymore, like, I give up. So model training is complicated, it's not easy, which is why most AI publications end up in, AI models end up in a publication and die. They do not get put to use. And we really don't know what the black box is looking for. There is something called explainable AI, which can tell us look under the hood to figure out what is the AI doing. But we're still early stages of this, and this is my most favorite area of research. There are things called adversarial attacks where you can modify an image and just trick the AI system completely. So it'll identify a dog as wine just by that minimal manipulation.
1 minute left.
Sure.
Thanks.
So the pitfalls of AI is that AI models are biased. They just learn, they copy mistakes, they are expensive infrastructure. So they're still preliminary. So if you hear a lot about AI taking over your work, don't believe it, it's not happening. So AI is not going to take over, it's just human with AI and augmented intelligence. That's the way we are kind of headed right now. Thank you.
Thank you, Dr. Amitha. It's time to take a few questions now.
Hi, thanks very much. I'm David Dickerley, a batch of 1982. So it's fascinating. It's kind of great direction, what I'm hearing, and things it could do. I'm just curious about the direction. Is there anything happening in children, such as retinal hemorrhages, as you would see in non-accidental injuries and so on?
So the AI is very specific to the disease. You cannot have a multifunctional AI right now. Diabetic retinopathy is for adults only that is approved. The children one is under process. It'll probably be end of the year, early next year, we'll have it ready. but it's there. The ROP one should be ready soon also. So we're getting there. They're still not completely okay, but we're getting there. All right.
So just use a mic, sir.
It was an excellent presentation for someone who does not know what AI is.
Thank you.
Now I request Dr. Beena Koshi to present the Certificate of Appreciation to Dr. Amita Rao. So our next speaker is the living legend and none other than Professor Nihal Thomas from the batch of 1982. He's a professor and head of Unit 1, a Department of Endocrinology, and formerly he was a vice principal of research and associate director at CMC Vellore. He has more than 320 indexed publications with a G citation index of 25,000. Including several areas of endocrinology and diabetes, and has authored 2 books, one of which is into the 8th edition. He has initiated the World Diabetes Foundation project to train 130 hospitals in rural India, and subsequently from Project Hope. He has supported the initiation of endocrine next-generation sequencing genetic laboratory at Vellore, and started the first comprehensive diabetes nurse educator program. His team and department were awarded the British Medical Journal South Asia Diabetology Team of the Year for 2015 and the Excellence in Patient Care Awards for the Royal College of Physicians, London, for outstanding work in advancing medical education and training. Presenting to you, ladies and gentlemen, Professor Nihal Thomas.
Thank you. Thank you. I'm overwhelmed. Maybe I'll have to disrobe my mask. Okay. My talk is going to be shorter than the introduction. So basically we have a problem with people who are lean, who have diabetes, and of course, Suviraj, I'm not going to be intruding into your space at all. I'm going to be talking about quite the opposite. And perhaps I should start by defining what is lean, a very ambiguous terminology. Lean, is it less than 23 kg per meter squared? Or is it less than 20? Really, it's a layman's term. So it's going to be heterogeneous when we talk about lean. But when you're talking about really malnourished individuals, you're talking about a BMI less than 18.5. And the problem is there is a lot of diabetes, perhaps 50% of what you deal with who are lean, who do not have type 1, and you need to figure out what that is. They say it's genes, not the blue variety. Environs have a role, and the lack of satiety. Epigenetics, low birth weight, problems for poor, dwindling secretion, and resistance for sure. So 7 scenarios commonly misdiagnosed as type 1 diabetes, and these are the scenarios. You might have heard of some of them, and I might be able to talk to you about a few of them in due course if you have not heard of them. And this is the list which we should keep at the back of our brains when we think about young onset or even middle-aged onset lean diabetes. So here is scenario X, 37-year-old man with hyperthyroidism on antithyroid treatment, started on oral antidiabetic agents but changed to insulin thereafter, complained of weight loss, increased appetite, osmotic symptoms, and no history of ketoacidosis or a family history. So he was obviously very lean, BMI of 16 kg per meter squared, had a palpable thyroid gland with a bruit, and otherwise systemic examination was normal. So when we have lean people, we must, of course, do 2 things. We should check their autoimmune status, and we need to look at the abdomen and see if there's anything wrong with the pancreas. The abdomen was normal, but we did the antibodies, which is specific for autoimmune diabetes, and this is the GAD antibody, which is high, and he had very low C-peptide indicating decrease in secretion, and of course, he's also thyrotoxic. So this is called, this is the forme fruste of type 1 in an older person, more than 25, and we see people now who may be insulin requiring very early at the age of 60 or 70 who have this condition called slowly evolving immune-related diabetes. So this condition differs from type 1 in the fact that usually only a single antibody is positive. We have a only one is usually positive, the GAD usually. They have mild insulin resistance, which is unlike general type. Hand side of the screen, they do not have any pancreatic disease. 33-year-old gentleman, a laborer, abdominal pain. Once again, no nutritional deficiencies, mild epigastric tenderness on examination. And so this chest X-ray was done to rule out tuberculosis. And what does it show? It shows calcification, large, chunky calcification of the pancreas. This disorder was reported initially in post-mortem studies by Dr. Paul Stephen way back in 1954, when I think he was a tutor in pathology. But then subsequently, it has been reported in Indians, particularly from Kerala. And this is called Fibrocalcic Pancreatic Disease. They have malabsorption, which is very obvious. This patient was more unfortunate, and you can see the CT scan, which shows a mass in the head of the pancreas has developed a malignancy. So this indicates the marker for pancreatic malignancy is strongly positive, because the prognosis in this patient is guarded, and I'm going to go into the rest of the story about biopsy, proven and adenocarcinoma. But what about this disorder? It is still there in India, and it is being missed. You should do an imaging of the pancreas in everyone who has lean diabetes. There are no signs of insulin resistance. They have low C-peptides, and their abdomen, an ultrasound might miss it in about 10 to 15%, so doing a CT would be the best thing, and they have a 40% risk of increased malignancy if they cross the age of 50. So what's new and what have we found out with pancreatic diabetes? They have a high proportion of osteoporosis. It is related to the malabsorption, not vitamin D deficiency. 60% have autonomic dysfunction. Energy expenditure is exaggerated and increasingly high, and so their dietary requirements could be very much in excess of 2,500 calories per day. And micronutrient deficiency is common in these individuals. One thing we should realize is that with type 2 diabetes, over a period of time, they may also have significant malabsorption, and if you start doing stool elastase in older patients with diabetes, you can actually get a profound malabsorption, which can be mixed up over here. Holistically, we have done a study with another institution in India, and what we have found was in younger patients with diabetes, increasingly type 2 is becoming common, but of course they tend to be obese or as well high normal BMIs, if at all. And the other thing is a condition called maturity onset diabetes of the young, very affectionately called MODY, which may also be seen in some of the younger patients where you miss the diagnosis. 16-year-old with diabetes, thrice daily insulin, had renal stones, DJ stenting, not attained menarche, no steatoria, mother pre-diabetic, aunt diabetic. BMI, low normal. Physical examination, Tanner's staging, basically indicating more or less reaching puberty. But she's not menstruating. So what does she have? Well, somebody told me maybe she has Turner's. We checked the FSH and LH, they were in the normal range. So we did imaging, and then we found that there was a biconate uterus over here, and the pancreas is atrophic, but there's no calcification. So this is a genetic atrophic pancreas syndrome, and there are about 10 syndromes where you can get this condition, which we should think about. But this is a disorder wherein Mullerian duct defects are also present, and it's called MODY5. Maturity onset diabetes of the young, wherein you can get the spectrum of anomalies over here. And the prognosis is vastly different if you detect it early, treat the renal condition early, and also handle the other reproductive problems that they have. The majority onset diabetes of the young, we've done a lot of work in this particular area, and my scientist over here is a bright guy who set up panels for around 400 different disorders, and we've looked at MODY in particular. It's different from what we see in Western countries. The pathogenic spectrum that we see is actually very different from the Western population. And this is important to understand because traditionally the common forms of MODY in the European countries, MODY 1, 2, are more sensitive to sulfonylureas, whereas some of these don't respond to sulfonylureas at all. Lean women with diabetes in India may in fact have MODY, and this insulin requiring spectrum, more severe endocrine spectrum of GDM, we found about 16% who actually had a MODY mutation as a cause for diabetes, and was therefore not pure gestational diabetes. So in the Western forms, if you're Keen 1, 2, and 3 are common, but the Indian forms of MODY are actually quite different. And this is the spectrum that we need to understand. Some are super sensitive to sulfonylureas. Some need mega doses of sulfonylureas, even in neonates or young children, needing up to 40 or 50 milligrams of glibenclamide per day. Very unusual condition it is, but responds and does not need insulin. So scenario 3, 38-year-old lady diagnosed to have diabetes at 19 years of age, had hyperosmolar systems, diagnosed as type 1, BMI was low, had enlarged veins on the limbs. This is called phlebomegaly, prominent muscles, and had prominent diabetic retinopathy. Striking feature, triglycerides very high. This does not happen in type 1 diabetes. She defaulted from insulin, stopped her 250 units of insulin 3-4 days, no ketoacidosis, proteinuria being present. So what are the differential diagnoses? So we did a body composition and we found the percentage body fat extremely low, less than 20%. In type 2 it goes in women more than 25, 30% or so. So this is called a lipodystrophic syndrome, and they respond, some of them respond to small doses of pioglitazone particularly, and this is another form of lipodystrophy wherein they get stunted called the complete lipodystrophic syndrome. Scenario 4, 20-year-old gentleman, polyuria, polyphagia, polydipsia, 4 years on insulin therapy, basal bolus, and has, despite reasonable control, also has dribbling of urine and bedwetting. Manages type 1 diabetes. So, grossly uncontrolled diabetes. And interestingly, the sodium is borderline high, and we found the urine osmolality also very low, indicating a concentration problem. So this is a combination of diabetes mellitus and diabetes insipidus. And her sister over here, 8-year-old, was also diagnosed with diabetes, but had a rapid deterioration in vision, hearing, and unfortunately passed on at the age of 26 years. So the patient was screened for the classical MODY panel, which was negative, and then we went further and did an extended panel, and we found this particular mutation positive. This is called Wolfram Syndrome or Wolfram Syndrome variant. And this is a condition, once again, which can be mistaken. We can have Wolfram Syndrome variants who are GAD antibody negative but do not have the hearing or visual problems at all. It's been published more recently, and we found a founder mutation in a family in Kerala with Wolfram Syndrome variants. The first founder mutation in Wolfram Syndrome which has been described. This is the spectrum of what you can see in Wolfram's, but remember, Wolfram's-like syndrome need not have any of these neurological conditions which may be there at the same time. Scenario 5, ketosis-prone diabetes, not just going very briefly, not going to present a case, but it was not reported in India till 2016 or so. But this is a condition where you can have ketoacidosis. Looks like type 1 when they come in, but when you give them insulin, and in 3 or 4 months' time, you can actually taper off the insulin. They come with ketoacidosis, Kussmaul's breathing, etc. And over here, this condition is called hybrid diabetes. So we have established that this particular condition exists in India. Should take 1 minute of
1
time,
minute
if you
more,
don't mind.
please.
Yeah. Finally, I will come to malnutrition modulated diabetes, a condition which was abolished from the WHO classification way back in 1996. And we feel appalled by that because we know that in rural parts of the country, in mission hospitals, Orissa, Chhattisgarh, Bihar, this condition actually exists. And it has been, well, it's not there in the WHO classification. We thought about it because of the Barker hypothesis work we did initially in the Chad cohort with our colleagues from Chad. And here is a typical lean diabetic, ultra lean, BMI less than 18.5. This is our work which we have done and published more recently, where we did clamps, deuterated glucose measurements, looking at the hepatic glucose output from the liver, insulin secretion low but not low as type 1, hepatic glucose output which is higher than type 1 but not as high as type 2, and they have abnormal fat distribution. But the interesting thing is this condition actually responds to oral antidiabetic agents in 50%. Why, we don't know, but they probably have an affinity for sulfonylureas, and there is a sulfonylurea receptor domain over there which probably responds to that. They have micronutrient deficiencies in addition, and this is the summary of this particular condition. So when you see a lean person with diabetes, take a detailed history, physical examination, measure C-peptide, it's very important, and do an ultrasound of the abdomen at the least, and check your GAD antibodies as well. Now, if that's negative, then you need to start thinking of other things. This is the spectrum, what you need to be thinking about, and thank you very much for your patient listening.
Thank you, Dr. Nihal, for that excellent talk. I think every time we listen to you, I think we learn something new. Thank you for that. Open for questions.
Okay, I'll start with one. Sir, you have talked about lean diabetes, and we know diabetes in the obese. What is the difficulty in, which is more difficult to manage and which has a better outcome?
So, okay. I think you have to have an algorithm and an approach to handle something before we answer that question. But perhaps when you have an obese person, and now we have cluster differentiation of type 2, that's making type 2 also a little more complex. But to understand that, you can have milder forms of type 2 diabetes who are largely obese, but the diabetes per se is mild. So you put them on a diet restriction and you try to make them exercise on a small dose of metformin, they respond. And maybe you might have to add one more oral antidiabetic agent at the same time. Type 2 has a spectrum. So you have the other end of the spectrum of type 2 wherein they need maybe 3 oral antidiabetic agents or insulin maybe within 5 years' time. So it's a very big spectrum. When you talk about lean, you have the DDs here. So each one of them needs an individual approach to be handled.
If there are no further questions, may I request, oh, there's one question there.
We'll just pass on the mic to you.
We usually give a lot of lifestyle modification for obese individuals having diabetes, but are there any lifestyle modifications that are available for lean diabetes?
No, certainly. Definitely exercise will help in any form of diabetes. Having said that, the overall impact of exercise in a type 1 is going to be less impressive when compared to a type 2. So type 1s also have to focus on their monitoring frequency. The glucose monitoring frequency has to be high. Their timings of meals have to be much more precise. As you know, that they may even have an earlier glucagon deficiency as well, which might predispose them for more hypoglycemia more easily. So the discipline in terms of lifestyle has to be done. Many of these young people actually pick up these disciplines quite well when you try to train them. But of course, you need to handle the psychosocial issues in addition in a major way. Yeah.
Thank you, sir.
There's one more question.
So, sir, my question is, what is the community prevalence? As in, in general, when we know, people who are obese are prone to have diabetes, but then how the lean diabetes, in the case of lean diabetes, how often are patients aware that they could be having a possibility of diabetes even though they are lean?
So these are patients who usually have some symptoms. Unless you have maturity onset diabetes young, which can be a very silent disease, strong inheritance, strong autosomal dominant pattern of inheritance, etc., they can be silent for many years. You could even have MODI for 10 years, some forms of MODI, the oral antidiabetic agent forms, wherein they may not have any symptoms for a long time. But most of the other lean forms are symptomatic. There is one or some symptom or the other, either hyposmolar symptoms or some of the other symptoms and parts of the syndromes that they actually have underlying.
Thank you for the questions, and may I request Dr. Susina to give the certificate of participation to Dr. Nihal Thomas. Thank you once again for an excellent presentation.
So our last speaker is from the special reunion batch of 1997, Dr. Ankit Bharat. I have known him as a very diligent and respectful junior, and if my memories are correct, I was a senior supervising him and Dheeraj when we served tables during the graduation day dinner. He has definitely come a long way after that, and is a pride and joy of the batch of 1997. He provided only a one-line CV, so I had to scorch the internet for more information. In 2015-16, Dr. Bharat was the recipient of the Lung Association's biomedical grant for his project titled The Role of Carbon Dioxide in Stopping Lung Healing After Lung Cancer Surgery. He rose to stardom during the COVID-19 pandemic when his team, under his leadership, performed the first double lung transplant in a 20-something-year-old lady who had irrecoverable lung damage due to COVID-19. This was in Northwestern Medicine in Chicago, where he is the Harold and Margaret Method Research Professor of Surgery, Chief of Thoracic Surgery, Director of Lung Transplantation. Ladies and gentlemen, Dr. Ankit Bharat.
Well, good afternoon, everybody, and thank you. I want to say thank you to my colleagues for also selecting me to be the scapegoat here. But you know, it's really my pleasure to be here today. But it's also a little bit strange because I remember just yesterday, well, 25 years ago yesterday, we were sitting here, and I think Deepu was there, Santosh Santi was there, and Vijay was there, and we were really laughing at this faculty who was working in US, and he kept calling beta, because he had been in US for a while, and I stand today here at risk of doing the same thing. So, you know, having spent 20 years of my life in the US, so if you don't get anything out of this, you know, hope you get a laugh by how I'm going to pronounce certain things. Now, I was asked to talk a little bit about the work we've done in COVID during the pandemic. I'm a cardiothoracic surgeon at Northwestern, which is located in Chicago. And Chicago actually had the second case of COVID in the United States. And at Northwestern Medicine is the largest healthcare organization in the Midwest, and we are located really at the heart of downtown Chicago. So we knew we were going to get hit by COVID, so we had to very quickly adapt to the you know, the incoming surge. This is, you know, the title picture actually shows you an example of how bad this disease can be. On my left hand, the red color lung is an explanted lung of a COVID patient with COVID, and in my right hand, there is a new lung that we are about to implant. So, now, how did this come about? So, as I mentioned to you, we had the second case, and we had to very quickly adapt to the incoming surge. Now, one of the things we learned early on in the pandemic was that this is not a hospital-acquired disease. It's a community-acquired disease. And what I mean by that is reflected in this figure, which we ultimately published. Despite doing a number of high-risk procedures, including bronchoscopies, tracheostomies, intubations, and whatnot, none of the providers and none of the residents and fellows got COVID during the pandemic. Now, obviously, that's predicated on having the right protective equipment, having the right isolation wards, but this initial observation really allowed us to get comfortable with this disease and start doing, really providing high level of ICU care to these patients. This is before any of the, you know, the tocilizumab trials or the steroid trials had been published. Just by giving them high level of ICU care early on in the pandemic, we, at our center, we had a mortality of only about 19% for patients who had severe COVID-19. And this is when most papers were showing 80% mortality for these patients. So we truly believe that just the really high quality ICU care was really essential. And that included pretty frequent bronchoscopies in these patients because they were dying of a lot of accumulation of thick secretions inside the airways. That also allowed us to quickly collect longitudinally a lot of samples from these patients who were dying early on in the pandemic, and in our research labs developed certain surrogate models. At that point, we didn't have mouse models, now we have, but at that point, we were able to use certain surrogate models to study the pathogenesis of COVID-19 ARDS, or acute respiratory distress syndrome. This is a paper that ultimately was published where we found that unlike what everybody was saying, which is that COVID is exclusively dependent on ACE2 receptors to enter your body, we actually discovered an alternative pathway through which the virus gets into your lungs. It infects the alveolar macrophages. That infected alveolar macrophages then produces certain chemokines, recruits the T lymphocytes. They multiply, they kill the alveolar macrophages, and then ultimately they start to, as shown in this illustration, they start to recruit these classical monocytes, which are circulating classical monocytes in the blood. They get recruited into the alveolar spaces. They differentiate into macrophages. But the difference between the original macrophages is that these are very profibrotic, and they produce tons of enzymes and catalysts that actually chews away the lungs. This observation then got us into the second step, which was to somehow get actual lung tissue from patients. And at that point, we were doing lots of regular autopsies, and doing regular autopsies required a pretty thorough decontamination process of these lungs, or of these patients, because you don't want to risk dissemination of the virus. So we started the first warm autopsy program in the United States, where within 45 to 60 minutes of someone dying, our team would enter the patient's room and perform the autopsy, collect those tissues, and really start to study the morphology and the basic pathophysiology. And one of the observations we made was, as we took out the lungs from these patients who had expired, they were literally melting in our hands. This is something that we had never seen before in other types of respiratory viruses like influenza and so forth. And that correlated with the histology, which was in a number of these patients where we found the basic architecture was really lost. So that observation then led us to hypothesize that in some patients, this disease is so severe that their lungs will not recover, because in general, respiratory viruses, they're considered to be recoverable. So influenza or RSV and stuff like that, you can get lung injury, but for the most part, you recover. But this was the first time we felt that these lungs are probably not going to get recovered. So how do we prove that? So, this to prove that, we actually thought of this this example of these growing up. We had these leaves, green leaf chlorophyll, and you blanch those leaves, and you can see through that leaf, and you can see the basic framework of that leaf, including all the stems and stuff like that. So we developed a tissue clearing protocol for human lungs that allowed us to take all the debris and the cells and all that out of that, and then really pass a light to study the basic framework of the lung. And the hypothesis there was, in some patients where the damage is so severe, the basic framework is going to be lost, and those patients potentially will require a lung transplant. So this video on the top shows you what a normal lung looks like with this tissue clearing technology that we had developed. So you can see the basic framework. If you were to take all the, the wallpaper out of this building and so forth, the wires and the struts will look like that. But when you see the COVID lung, it'll come in a second, you'll see that the basic framework is destroyed. You can see these are all just inflammatory cells in just one big bag of pus. And this was the first clue scientifically indicating that in some patients, lung transplant is going to be required. So how do we then predict someone, a patient, how do we predict that someone who gets COVID will develop recovery versus someone who will not develop recovery? So we, I'm a big believer of using unbiased approaches in research. So this is one of the unbiased approaches that we have used very commonly in our research program. It's called single-cell RNA sequencing. Some of you may be familiar with that. But essentially what this is you dissect out the lungs in all individual cells and then study the gene expression profile of every single cell in that lung. And as one of the prior speakers alluded to, it's not humanly possible to understand all those pathways that are being upregulated in individual cells. So we develop AI-based tools to study that. And essentially, simply put, what we ask is, what's different in this particular lung compared to a normal lung? Kind of like that oranges and apple analogy. So that led to the discovery of these specific cells, which we call the keratin 17 cells, and we validate that using special staining. So here you can see these pink cells in patients who have COVID-19. And interestingly, what we observed was these pink cells were next to these green cells, which turned out to be very potent fibroblasts. So this keratin 17 cells was present in every single COVID patient who did not recover beyond a certain point. And interestingly, we also found that in all patients who required transplant for non-COVID diseases. So it seemed to be a marker for end-stage lung disease. We took this a step further to understand what is these keratin 17 cells and the fibroblasts. Are they mechanistically linked together, or is just an epiphenomena where they just happen to be there? So using some contemporary bioinformatics tools, we can ask those questions using, I'm not going to have time to go into all of that, but using those bioinformatics tools, you can start to ask how these cells are interacting with these other cells, or any cells in that dissected lung, or any tissue for that matter. So here you see the keratin 17 cells, which are labeled as aberrant epithelial cells, and all these interactions, each line represents the interactions. And you can then get more granular into every single line. A representative is here, and we found that these aberrant epithelial cells are causing the replication of these fibroblasts using this platelet-derived growth factor pathway. So we are looking at certain medications, there's certain compounds that we've developed that will allow us to block that. So in the interest of time, I'm just going to skip ahead and then just show you what this may look like. So this is a intra-op imaging, intra-op video of a patient that we are transplanting 9 months into the COVID-19. So this right side is a new lung that we just put in there, and the left side is an old COVID lung, which we are trying to inflate with a 70 of pressure, and you can see it's barely moving, while the other lung is just, very quickly, inflating even with the 10 of inspiratory pressure. So, it really is an important treatment for some patients who don't recover. How we go about making that decision, we have keratin 17 staining along with some clinical decision making, but not everybody has. That's something that we have published in some recent papers, and in the interest of time, I won't be able to get into it, but it's really a life-saving tool that has been adopted. We put together a consortium of international centers, including India. Center MGM Chennai was one of the first ones to do a COVID transplant, and I believe they've done multiple more. Southeast Asia, Europe, and in North America, it's been pretty widely adopted. And as of yesterday, over 1,500 transplants have been done for this indication globally. Thank you.
Thank you, Dr. Ankit. Any questions?
All right. My question is for the keratin 17 cells. Is there any difference between them in each of the variants, or is it pretty similar for all of COVID?
Yeah, it's a great question. So, they are they basically represent a differentiation defect from AT2 to AT1 cells. So normally what happens in the setting of lung injury is, the cells die, right? So they get injured, so AT1 and AT2 cells die. So typically AT2 cells differentiate into AT1 and then help. So COVID-19 skews that differentiation into this keratin 17 cells. And we are actually, there's a paper that's going to come out where we found how that de-differentiation occurs and how you can prevent it. So when they get into that pathway, then they start to produce a lot of pro-fibrotic factors that allows the fibroproliferation to occur and long-term lung fibrosis to occur. But you can alter that pathway, or you can get back from keratin 17 back to the AT1 using modulating those pathways that we've recently discovered.
For record, that was Pradeep's son who asked the question. Prakash's son, sorry. And Amita's son, okay, so I think he's doing medicine, I presume? No way, okay, all right, okay.
I have a question. Being in this field, okay, can you give us advice as to vaccination by any chance? The fourth dose?
Yeah, clearly we've seen that, the vaccine reduces the severity of this disease. All the patients, so we've done over 75 transplants at our center with 100% survival, and everybody except one was unvaccinated. So vaccination will definitely reduce the burden of this disease. Sorry?
I think there's one more question.
Supposed to be given. Is it, we had our third dose, okay? The third dose is supposed to come 6 months after the second dose or what? And now the fourth dose is supposed to be 6 months after third dose or 1 year after third dose?
Yeah, that data is unclear. I think everybody should, again, I'm talking about the mRNA-based vaccines, AstraZeneca and the Indian version Covishield. I don't have enough experience with that, but for AstraZeneca and for the mRNA-based vaccines, first 2 doses are pretty effective. And then after that, depending on your risk profile, you should be taking the boosters. That's what our data suggests. And whether you do it 6 months or 1 year, that's really, that data is unclear, but at least on an annual basis, it's definitely effective.
One question from me, Ankit.
Yeah.
We just had a path-breaking research of a transplant from a pig to human by knocking in and knocking out genes.
Yeah.
Do you think it's going to become a reality for lung transplant?
Yeah, I think lung, it's not going to work. I think for pig, that's just my personal opinion. And the reason I say that is I think 3D printing is going to get into clinical transplant for lungs faster. And the reason is, the heart is easier when it comes to xenotransplant because it's a pumping function. But there's a lot of physiologic, immunological functions that the pig lungs will not be able to replace the human lungs. That's why I don't think a pig lung is going to work in humans. For the same reason, I don't think pig livers are going to work in humans, but we'll find out in the future. So the same company that actually bought all the pigs, United Therapeutics, I think everybody, especially medical students, I would really encourage you to read about her, Martine Rhodenblatt. She's actually a transgender woman, and she had a daughter who was suffering from a pulmonary hypertension, and she went on this real spree to develop all these cutting-edge technologies. Now, heart transplant from pig came before the lung transplant, but it's really a very inspiring story that I think everybody should read. I don't think for liver and lungs. So they're actually developing 3D printing for lungs where you take, the basic scaffold and then you decellularize it and then recellularize with the progenitor cell. That they're getting close.
For an interest, is that a book that?
No, I just wanted to leave with my email. One of the things I wanted to share with particularly medical students is, when I was, 25
Because you are next.
Here, I felt, the speakers, and throughout my journey, I think Anand mentioned, you're going to be okay, finish your, tasks and so forth. Benji said, okay. But one of the things I think what CMC really taught me was to be able to work with in many different environments, from a small village to some of the most cutting edge, wards and stuff like that. So I hope the medical student, as you go through your journey, you cherish that and you're able to gain that experience in many different setups. COVID was a classic example. And in fact, the reason I said in this email is if I could be of any advice, please feel free to reach out. We have a very large research program, and we have a very big clinical training program. If I could be of any help. Chicago is a beautiful town. You can see some pictures. These are taken from my iPhone. Not Photoshop, so it's a beautiful place. And some of the experiences that I learned at CMC are captured in this book. And I hope you guys enjoy your journey as you go through your medical training. And you're going to be great. Thank you.
Dr. Prakash, I think we can take one more question if that's okay.
Yeah, that's another great question, because I didn't have time to go into that. So in a paper that we just published in JAMA, we actually outlined the probability of lung recovery with time. So if you take patients, all patients who go on ECMO or advanced mechanical support on day one, about 60 to 70% will get better. But that probability changes over time. So what we found is that by about 4 to 6 weeks, if they haven't shown a lung recovery, their probability of recovering goes down to less than 5%. So at that point, we start thinking about transplant. And even those 5% of the patients who recover after extended duration mechanical support, their 1-year survival is less than 60%. So those are the patients we start to think about transplant. Obviously, we look at some of these biomarkers at our center using keratin 17 and so forth. But time is about 4 to 6 weeks. We definitely start thinking about transplant.
Yeah, thank you, Dr. Ankit. We request Dr. Beena to present a certificate of appreciation to Dr. Ankit Bharat.
So thanks a lot. Loved how Praka came and asked a question in just shorts, like how he does in hostel. Okay, so with that we come to the end of this CME. I invite Dr. Alfred Daniel on stage to give a memento to Dr. Susina on behalf of the Alumni Association and all of you. Quick announcement saying that batch of 97's inauguration of the Oval floodlights will be on immediately after this. We'd like to apologize that I will not be able to come for that, but we hope that goes on well. Thank you all for attending this session. We will meet again tomorrow at 8 o'clock for the tree planting. You don't need to bring your own trees. We'll provide the trees. We'll go on to the rest of the program, including the annual GB after that. Those of you who want CME certificates, you can contact Nirmal or give your name I think there is a paper put there, and we will give you the certificates. I will be floating around here for the next half an hour or so. Dr. Alfred will be available. If you want to contact us for any particular doubts, please do so. Just a quick check with batch reps. Entertainment requirements, please contact Dr. Divya if possible now. And also those of you who would like to take part in the chapel service, please do meet one of us or come here tomorrow at 4:30 in the afternoon. Thank you. It's been great. Good to have all of you here. And do interact with each other as you go on. Thank you. See you all tomorrow morning. God bless.